Put the case number 1. Okay, Naomi, start reading.
Okay, sir. This case is 17-year-old boy, pain recurrent over the lateral side of the right hip since 18 months. No rest pain, no radiation, recurrent limp over the right side, and there is no history of weight loss.
Okay, right. Move the next slide.
And on examination, he has got pain, patient with an...
There is a format in which we are going to proceed. The first, we will give you an outline of the patient's complaint, then clinical examination finding, and from there we will stop. Then, we should reach a level of diagnosis, a possible diagnosis or presumptive diagnosis. And we'll discuss at that point, and then we will see the X-ray and investigations and reach a final diagnosis. This is how it is going to be on all the cases that we are going to discuss. I think we have got only 1 hour. We will try to, I think the cases that we discuss, we will discuss in detail rather than going, we have more than 20 cases, but all these cases cannot be discussed. So we'll take representative cases and then we'll discuss. Okay, that's the plan. So Naomi has given you the history. Naomi, can you once again read so that you...
Yes, sir.
Yeah. Okay, once again. Now, with this idea, every student should be listening. So we are talking about a 17-year-old boy who has pain in the lateral side of the hip. There is no rest pain, no radiation. Yeah. Recurrent limb on the right side, and there is of 1.5 years duration, and there is no weight loss. So here you have to think like, yes, what am I facing? What is the possible problem for this patient? Patient has come to you. Now, then you are listening to the history. From listening to the history, you have to reach some level of diagnosis, the possible diagnosis. That is what every student should achieve, listening to the patient. You have to see the patient also. Then you look at the patient, what is happening to the patient and how he's behaving to you, what is the attitude of the patient. All those things are important. But in this type of virtual class, it is not possible. So you have to understand this particular point and then start thinking. Okay, now go to the next slide. Okay, on ready.
On examination, patient has an antalgic limb, no deformity, wasting of the thigh and gluteal muscles, no local warmth, tender trochanter. Trochanter is broadened and thickened, and there is no upward migration. On examining the movements, there is pain in the lateral aspect of the hip.
All right. So I think, with this, who is another person here? Who is there? Karthik.
Yes, sir. Yes, sir.
Yeah, you come to, come on video now. Oh, yeah, right, fine. So what do you think is the possibility from listening to this history and the clinical finding? I will put, options for you. If you when you start learning about bony swellings in your undergraduate days from the DAS, if you look at that and read carefully, you will see that most of the conditions that you get will be in 4 groups. One is an acute infection, second is a chronic infection, and third is a benign lesion, and fourth is a malignant lesion. So among this, you need not make a diagnosis here. Broadly, which condition you believe it is?
Sir, it could be a benign lesion or a no history suggestive of chronic infection, sir. So it most probably suggests a benign lesion.
Okay. Anyway, it is not an acute infection.
Okay. Yes.
18 months.
Not a chronic infection. I think it's a benign lesion. Why not a chronic infection?
No constitutional symptoms, like no history suggestive of any infection.
No fever.
It's all
18 months.
Yes, sir. It's more than 1 year, sir. So it wouldn't be an acute infection. It's a chronic infection. Sir.
No, it can be a chronic infection. I'm asking you what is the most common chronic infection that we have?
Tuberculosis.
Or the
Tuberculosis, sir.
Tuberculosis.
Can it be tuberculosis?
No weight loss.
No weight loss.
Still wait.
Yeah, on clinical, that one. Other than that, what is the type of pain that we get?
A night pain.
There would be rest pain, sir.
Pain.
And
Rest
night
pain.
pain.
Night cries.
Important that you get
Night
rest
cries.
pain. There is no rest pain. The chronic, no weight loss, and from this, any point to say that it is not infection, chronic infection?
No local warmth.
So local warmth is not there, sir.
So we expect local warmth at that area, right? So there are
There
points.
can be sinuses or some tracts or something also, which is not observed here. I mean, which is not told here.
Yeah, but every case of tuberculosis need not have a sinus. Then abscess develops and it bursts. Then only you get a sinuses. Absence of sinuses, not a point against. Okay, so now we'll go to the next slide because from here. So wait. Now can you tell me? You said it's a benign lesion, and you also said it is a benign lesion. Among the benign
Yes, sir.
lesions, which are the
So it's in the proximal femur. The proximal femur has a yes, sir.
Fibrous dysplasia.
fibrous dysplasia? Okay, then
Any
Simple bone
cystic lesions
is-
also.
Yes, it's
Simple bones.
which
Simple bones.
you are talking about?
it could be an aneurysmal bone cyst.
Aneurysmal.
Cystic lesion.
Then anything else?
Non-chondroma.
Fibroma.
Non-ossifying fibroma. Yes. Then when you make these statements, you should be able to substantiate, reason out from the clinical findings, location, why you. That should be the way that you should go. So,
Is chance because
Sorry?
the trochanter broadened and thickened. Okay, I'm done.
Your voice is breaking.
We'll proceed. The thing is, the way that you should have to argue for this point. Naomi, what's the age of the patient?
17-year-old, sir.
Second decade situation. Right. Where is the location of this lesion?
Metaphysis.
How do you know it's metaphysis?
Trochanter.
Trochanter is metaphysis?
Proximal femur, sir. So,
No. There is clear description here. There is thickening and broadening of the trochanter.
Yes, sir. So
I think anybody in this group of postgraduate students can answer this question. Where is the lesion?
it is pertaining to the cortex.
I think you should understand trochanter has got an epiphysis.
yes, sir.
Okay.
Epimetaphyseal lesion.
Maybe that I agree. It can be an epimetaphyseal lesion. So epiphyseal lesion extending up, and that's an epiphyseal lesion. So if it's an epiphyseal or epimetaphyseal, only X-ray can tell you. But which lesion? Which are if it is in the epiphysis? Or in other words, I will ask another question. When does the epiphysis disappear? or use with the bone.
Epiphyseal lesion could be a chondroblastoma.
Yes, it can be a chondroblastoma. Anything else it can be?
Giant cell tumor.
Giant cell tumor, yes, it can be. Then
But giant cell tumor only after the skeletal
epiphyseal closure.
maturity is
yeah, exactly.
after epiphyseal closure is.
Yeah, but that is why I asked this question. When does trochanteric epiphysis fuse? It is 14 to 18 years, right? So it is verge of closure. We don't know. So I think if you take too much of time, we will finish with one case. You answer very fast. We'll go back to the next case, X-ray. Now, Jonesy, read this X-ray.
This is a plain radiograph of a skeletally mature person showing the pelvis.
Are you sure that's skeletally mature?
Yes, sir.
All right.
Yes, I think it is.
It's skeletally mature.
For skeletally mature, showing the pelvis, and on the right proximal femur, there is a lytic lesion. Lytic lesion over the trochanter. It's its margins are well defined, but there is some sclerosis.
Inside the lesion.
Calcification.
Then go fast. Don't waste time like this. You will not finish any of these cases. So go fast. Okay, see, there is a lesion which is a geographical lesion. The borders are well defined. And when we talk about describe any lesion, you start from the center of the lesion or the matrix of the lesion. That is what we talk about. Then you have to location. Where is the location? It is extending up to the tip of the trochanter. Am I right?
Yes, sir. Up to the tip of the trochanter.
So it is in the epiphysis extending into the metaphysis. What you said is correct. It's an epimetaphyseal lesion. Okay. Now the
lesion, yes, sir.
and you can see some speckled calcification, as you said, in the matrix, like that. What has happened to the cortex, outer border of the cortex? Has it broken the outer border of cortex? No, just
No.
is there
No,
a reaction?
It's not broken.
There is
No
no
pains,
reaction. So it's a
Not,
well-defined lesion in the epimetaphysis of the trochanter with speckled
there
calcification.
is some.
Yes. Anything else?
With no periosteal reaction.
No periosteal tissue involvement. That will be the description. It should go very fast. And as a student, you have a plan. First, the matrix, the lesion. Whether sometimes it is purely lytic, sometimes osseous matrix is there, sometimes chondroid is there, then sometimes fibrous, that ground glass appearance is there. Then you go to the margin of the lesion. That is the edge of the lesion. So the margin of the lesion is well defined, ill-defined, or the zone of demarcation is otherwise called. So it is narrow or wide, and if it is narrow, is it sclerotic or not sclerotic? Or some area it is sclerotic, some area it is not sclerotic. And if it is extending beyond that, is it permeative or mouth-eaten? What is whose classification is this, Naomi? Who has classified?
Lord's classification.
And all the students who are listening to this, you should go back. You are getting certain points. We will not discuss everything here. You should go back and see what is Lord's classification and how you represent. You present an X-ray, describe an X-ray. This is the way that you are doing it. So first is the location, second is the type of lesion, third is the matrix, fourth is the borders of the lesion. The fifth is the cortex. Then seventh is the periosteal reaction, and eighth is the soft tissue involvement of nerve. So now, Naomi, what you think it is? You have so many diagnoses we have mentioned. Among this, which one will you prefer here?
Chondroblastoma.
Chondroblastoma. Why?
So considering the age, then and the radiograph shows spectral type calcification also.
Yes, sir. You can say that it's a cartilage lesion, right?
Okay.
It can be a cartilage lesion. Then why?
And the location also.
Location also. Okay. So if it is a cartilage lesion, which are the benign cartilage lesions possible?
So it could be enchondroma.
Enchondroma. Go fast. You should be very, very. No, you should do dances.
Enchondroma.
Your voice is strong.
Yeah, Jonesy, your
Jonesy.
voice.
Chondroblastoma, chondromyxoid fibroma. Chondroblastoma, chondromyxoid fibroma. Osteochondroma, not likely here, but
No, I'm just
and
what are
enchondroma.
the cartilage lesions?
And enchondroma.
Enchondroma, chondroblastoma,
Chondromyxoid fibroma.
Chondromyxoid fibroma and
Osteochondroma.
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 So among this, which one is possible depending on the location in the
So
epiphysis?
epiphysis,
I would
chondroblastoma.
go
Epiphysis.
Chondroma.
Which are the other?
chondroblastoma, sir.
Forget about the age of the patient. Which are the lesions which are possible?
GCT.
Which are the lesions possible in the end of the bone in the epiphysis?
For GCT,
Yes, usually.
Yeah.
then
Yeah.
Keep must be very, very fast answer.
I would keep GCT.
GCT.
Hmm?
GCT.
ABC.
Yeah. Which are the lesions possible in the bone?
So chondromyxoid fibroma,
Any
GCT,
infections?
ABC.
The answer is
Infection, sir.
infection, chronic infection. Which is the chronic infection that you have? Tuberculosis
Easy.
comes as that first. Okay. Then intraosseous ganglion. Yeah. Then chondroblastoma. Then is there any carcinoma possible
Giant cell tumor.
in the epiphysis?
No. That is more.
Clear cell,
Soft
chondrosarcoma.
Clear cell one.
So in a child or before the epiphyseal fusion, if you read any textbook, you will find two lesions very common. One is chondroblastoma, second is clear cell chondrosarcoma. But clear cell chondrosarcoma is, it is extending into the other age group also, the third decade also. Okay, and it's a huge lesion. It's not a small lesion as you see here. Okay, so we'll proceed now with this diagnosis of why can't this be tuberculosis, which is more common in our system. Clinically, it cannot be. I'm asking radiologically.
Periosteal reaction will be there. When in chronic infection.
Wait, don't run away. The periosteal reaction is not a feature of tuberculosis. What is the feature of tuberculosis? Naomi? It is gross osteoporosis, what you call rarefaction, the word that you put. That's the word that we quite often use, not even the osteoporosis, much more than that. You won't see a sclerotic border like this in tuberculosis. That should be your answer. Okay, now, Naomi, what will you do now?
So I would like to get so the cortex and all appears to be intact. So I would like to get an MRI of this patient.
So definitely, first step is to go for MRI.
After MRI only, I would go for a biopsy, sir.
Biopsy.
Yeah, I agree. Why? Why do you think that MRI is needed here?
So for knowing
We
the
need to
soft
see
tissue involvement and medullary canal involvement.
Yes, Sunit Yadav, right?
Yes, sir.
Yeah. Then you are right. You have to go for an MRI. It gives you some idea, but diagnosis with MRI, calcified areas you can make out, and also you can know the thinned out areas, which are the thinned out areas here to take a biopsy, because your options come to the biopsy level. Then if you have a suspicion of something, for example, it can be a sarcoma, chondrosarcoma, then after the biopsy, this is not the right disease. So all investigations, so the basic principle is all the investigations should be completed, especially when you have a doubt in your mind before you go for biopsy. Okay, don't you think you need a blood examination? MRI is the first thing.
No, sir.
Yeah.
Along with the X-rays, we'll go for blood investigation.
MRI. So we'll see the blood. Okay. So these are the conditions we talked about in the epiphysis. Next. Okay. Now this slide is actually telling you this is from pathologic diagnosis of bony lesions by Greenspan. This was a wonderful book. You should take this book and read about this because here you get the age group. And what are the possible things? If you look at this 1 to 10, 10 to 20, like that, So in this group, it is 17 years. So what you see is these are the lesions which are possible in this age group. You get a list of conditions which are possible. So you can think about which is the condition which fits in with clinically and radiologically with the given situation. So you will not miss many things as you go. So this is a very good slide, and you should get this. So X-ray chest was taken. What is the relevance of this? Naomi, do you think you need an X-ray?
Pulmonary tuberculosis.
Yeah, one. Why you want to look for pulmonary tuberculosis? It can be lesion in the bones without any involvement of the lung.
Metastasis.
Secondaries.
Secondaries of what?
GCT.
Yeah, you need even chondroblastoma, which we are talking about, an epiphyseal lesion, and that also can have. And the first question that I asked, without changes, you can have lesion in the trochanter, the tuberculosis we're talking about. The answer expected from the answer expected is that osteoarticular tuberculosis is always secondary. There must be a primary lesion somewhere. So in chest, it can be from the intestines, it can be from the glands. So we are just, or even if when you are suspecting, you will always take X-ray. That should be the answer that. Okay, so we need chest X-ray. Okay, for all those purposes. So we have discussed this in detail now, and if look at this is an epiphyseal lesion, a geographical lesion, well defined, stipple classification, reaction. We have discussed these things. And your diagnosis will be GCP or and there is a blood investigation. And this also we have discussed. It is not infection because of these reasons. Benign lesion most possibly, and malignant lesion, the features are. So, okay, coming to the management now. See, we have seen, we don't have an MRI taken. I think the MRI was with the patient, so we don't have that copy of it. MRI was giving a diagnosis of possible chondroblastoma bar GCT bar tuberculosis. Okay, now incisional biopsy is done. Yeah, and the diagnosis that we got was GCT from the pathologist. Okay, how will you manage? So the diagnosis was GCT. How will you manage this situation now?
Sir, curettage and brown grafting.
Okay, curettage and bone grafting was done for this patient. Next slide. Okay, this is the post-op, immediate post-op picture. So you can see that it is curated and grafting was done. And this is the picture. Now, what do you think is this picture? Does it fit in with the GCT, Naomi? We have gone for a number of CPC.
Chicken wire interference.
Yeah, what is that? What is that? What is that condition?
It is chondroblastoma.
Yeah, this is the classical picture of chondroblastoma because there is chicken wire calcification. And this is, probably you must remember this chicken wire calcification, and your need questions. This very commonly asked chicken wire calcification is typical of chondroblastoma. Okay, and you can see the cartilage cells here. And all these cartilage cells are peripherally undergone calcification, and that is what chicken. So these are the cells in the cartilage, and you can see the wire here like this, right? The chicken wire kind of calcification. And what is it now?
Chondroblastoma.
So the pathologists have changed now to chondroblastoma. Okay. So what is the? This is This is the X-ray 10-week post-op. What do you think it is now? Are you happy with the way that the disease is healing? So we took an X-ray. Sorry, CT scan. You can see where there is a gap there, right? So was it a recurrence of the lesion or a lesion which has not healed? And we did an MRI in connection with that. Okay. Okay. And this was the picture. And what we got was the opinion from the radiologist was this is spilled graft, and possibly that site has got fractured and it has not united. So this is over the time this has happened. This is the last X-ray that we have. Nami, can you tell me what has happened in 2020 to this particular lesion? What is it now? Okay, so that has gone for a fibrous union, and the patient is not having any symptoms. We are following up, and he is okay. Okay, so trochanter possible fibrous union. The patient is symptomatic on follow-up. That is the history of the patient. So this tumor is also known as Codman's tumor, right? This may be a question like that in your theory. Then you will have problems. See, I have seen this happen. So you will write something. You should know that. And here, okay. All these things we have discussed. So we'll go to the case 2. Okay, read this.
Sir, an 11-year-old boy missed a step on stair while playing at home. Had severe pain and deformity to the distal leg immediately. Unable to wear bait, was asymptomatic before the fall, and he went to a local hospital and was diagnosed to have a fracture of the distal tibia. X-ray taken, referred on suspicion of a pathological fracture.
So that is the X-ray. Read the X-ray now.
So the X-ray shows of a immature skeleton showing a well-defined geographical lesion with the narrow with sclerotic borders
First,
and
Location.
Yes, the location of the tumor is over the metaphyseal diaphyseal regions.
Metadiaphyseal region.
Diaphyseal region.
Okay.
And the tumor is the matrix of tumor is
Eccentric lesion or concentric lesion?
is an eccentric lesion.
How to define all those things? There is a step in describing. Next.
It's an eccentric lesion with a well-defined borders, and the
Matrix first.
the matrix is a bone cloud.
Yeah, you can see an osseous matrix.
Osseous
There is
matrix.
a lytic lesion, and you can see bony spicules inside.
Yes.
Right.
Yes, sir.
Okay. Yeah,
And
proceed.
there is a cortical break.
Yeah, before that,
There's
border of the lesion.
border. There is no periosteal reactions.
No, border of lesion is
Yes,
not
sir.
periosteal.
Sorry, sir. Then as a narrow.
Narrow. And I said there are three patterns there.
Geographical plan.
What is this?
Irregular.
This sclerotic border.
Sclerotic borders.
1A.
Yes.
Okay. Right. Then there's a break in the cortex.
Break. Yes, sir.
Because there is a pathological fracture.
Pathological fracture.
So that is the description. So what is the possibility looking at this X-ray and the history?
GCT, sir.
Yeah.
No, not DCT, sir, because it's an immature bone. So would be a cystic lesion, most probably an aneurysmal bone cyst.
Yeah. Non-ossifying fibroma.
It is a metadiaphyseal lesion. So probability of likely sir, than an ABC. But ABC also can be kept as a differential diagnosis. There are reports of ABC.
Yeah, right. I think I wanted to ask you questions, but because of the time, I think we are almost to the time. So ABC won't get the sclerotic border. Number one. Second, in matrix, even the citations that you have is not dense. Sometimes it can be department there or maybe there, but it is never like this. It's almost a purely lytic lesion. And it's an expansive lesion, eccentrically expansive lesion. This is also expansive lesion. That was the only point that you can say that it is ABC. There is also an eccentric lesion. Otherwise, all the features are against. What is said is the monocytic fibroma is a typical, this is typical appearance of a non-ossified. No, you look at the endosteal areas, you see a scalloping type of, right. So this ugly lesion with the fracture, you have got bony septations, and this is a typical of non-ossifying fibroma, and this is a one common site. Okay, now next slide. So it's a benign lesion, it's not a malignant lesion. Why it is not a malignant lesion?
Because the borders are sclerotic, well-defined and sclerotic borders. I've seen
No periosteal reaction.
no periosteal reaction.
Patient presented with a pathological fracture, but that tells you that this lesion was there with asymptomatic for some time, right?
Yes.
And this is not a lesion which is 1 week old. This lesion was there. So patient presenting with a fracture and you taking an X-ray like this always tells you that it's a benign lesion. Okay, that is this point. Next one. So then what is the age? Age is 11 years. Which are the possible group? Again, this help to pinpoint this. We cannot discuss. I want to discuss each and every one how it is not that particular lesion. So differential non-ossific fibroma, eosinophilic granuloma. So this is what I was talking about. Whenever you talk about anything, your location comes first. So if you look at the location, it is metadiaphyseal. It is in the long axis of the bone. What is that in the long axis of the bone means? Next you will understand that. A long lesion in a long bone, if it is benign, think about a fibrous lesion. That's a dictum. So that will give you the clue towards a fibrous lesion. Then it's got a sclerotic margin. to stop at 1 a.m. Then the bubbly endosteal scalloping and the lytic situations go next. Yes, how do you manage this condition now?
Non-ossifying fibroma, usually a pathological fracture will itself cause osseous union. It is a misnomer, so even though it is non-ossifying, after a pathological fracture, it will ossify and it will unite.
Fractures are usually treated non-operatively, sir, in non-ossifying fibroma.
And observed for it.
Why not do we fix it?
Yes, sir.
Hmm?
We can look for fixations.
You can fix it also. Right. So let us see what was done for this patient. Okay, that is immobilized, and you can see the angulation. See, fracture is united, but the lesion has enlarged in size. So what will you do?
If it's large,
Now,
curettage.
let you for curettage and then fixation. So.
All right. So next, right? Next. So this is 1 year picture. Now, without doing anything, because the patient was walking without any problem. So what will you do now? Will further support it?
Yes, sir.
Yes, sir. Because it might cause pathological fracture in the future.
Again.
Okay, next slide. This is 18 months lesion. He's running around, he's playing. So what has happened now?
So we can
You go
wait.
back to the first X-ray and what is next? You look at the borders of this lesion. Now, okay, 3 years later, what has happened? Last. What has happened now? Next.
Borders.
Now it is no more progressive.
Cause sclerosis or borders.
Process of the borders, the lesion has become more sclerotic, right? So there is a classification here, and what is the natural history? It heals at skeletal maturity, and this is now we read that.
Heals
classification?
skeletal maturity. 4 stages in
Whose classification?
Stage A represents an eccentric.
Which classification? Okay, and okay, then go read.
Stage A represents an eccentric lesion near the physis. Stage B lesions have variable distance from the physis with thin sclerotic borders. Stage C lesions exhibit increasing sclerosis, and stage D lesion shows complete sclerosis.
So where is our patient now?
Stage C.
Patient is in stage D. Usually it heals by itself. We have I think maybe 5-6 patients like this now. They're all on follow-up. We are seeing them, and as time goes on, as with the skeletal maturity, this all will heal. Okay, there is no need for bone grafting. If you get a pathological fracture, things are different. But here you can see that even pathological fracture, it has healed. Even if you cure it and graft that area will be again taken up by fibrous tissue, and you don't have the same type of bone there. So there is a paper on this. If you have more than 50% of bone diameter, you support to prevent a pathological fracture. What is the message? Non-ossifying fibroma, usually asymptomatic, becomes symptomatic once you get a pathological fracture and needs observation and heals at skeletal maturity. That is non-ossifying fibroma. Yes, shall we stop or proceed? Because I think.
So please proceed, sir. It's I think only.
No, it's 1 hour now, right?
No, sir. I think.
Yeah. Now, yes, read this. Now, we'll go fast.
Karthik.
3-year-old child.
Can do that. Anybody, it need not be from Amrita. Anybody can do it. Okay, do it.
Karthik.
3-year-old child, pain and swelling below the right knee for 3 weeks. History of limping present. History of fall 1 month back prior to the pain. had antibiotic course for 1 week. The swelling is reduced. There is history of weight loss recently. The patient consulted local hospital where X-ray is taken and is referred here for further management.
Okay. Right. Next.
Past history of surgery done for swelling when he was 1 year old. On examination, the patient limbs, there is a flexion deformity of 10 degrees. There is diffuse swelling noted in the metaphysis of proximal tibia. Small scar is noted on the medial side. Wasting of thigh muscles noted. Local warmth present. Mild tenderness on the medial and lateral side. Bony thickening is present. Irregular bony thickening of 3 to 3 centimeters noted. The soft tissues are within normal limits. The knee range of movement is from 15 degrees to 100 degrees. There is no lymphadenopathy.
Yeah, read this. This was the picture, blood picture. Okay.
Labs.
Yeah, next. Okay, now read the X-ray. Now, ideally, what you should have done is, because we don't have time, that's why I'm running through. We have to stop at the point of history and go for a provisional diagnosis. And this provisional diagnosis goes to a clinical diagnosis with the X-ray and all the things we have to do. So we won't be able to finish it off. So now read this X-ray.
Plain X-ray of the right knee showing a skeletally immature patient plain X-ray. Sclerotic lesion noted in the epiphysis and the metaphyseal region of the proximal tibia. Multiple septae are noted. Yes, sir.
Yes, sir.
You have already said that. Okay, fine. I told you, find the location first, then talk about the matrix, then talk about the cortex, endosteal, cortex, and then periosteum and soft tissue. You have not mentioned anything about the periosteum here, did you?
No, sir.
Is there any problem with the periosteum here, you see, in this X-ray?
There is a periosteal
Interrupted.
Reaction, right?
Interrupted.
That's found here. Okay. So now you have seen the blood, you have heard the history. What do you think it is?
Giants.
Anybody can answer, those who are in this group can answer. You can unmute and answer. There's no problem.
Yes, sir.
Okay. Now, the first question is it acute infection, chronic infection, benign tumor, or malignant tumor?
Chronic infection.
Why chronic infection? Why infection? Why infection first?
On examination,
Because
the present.
I think this is a very, very important point we are discussing, because every time this is the problem that you face in your exam.
Pain and swelling.
Okay. Pain and swelling, everywhere you get it.
History of antibiotic.
Antibiotic only.
Treatment history gives you something. Okay, then anything else?
Weight loss.
Weight loss. And one very, very important point you have not picked up. You only swelling reduced. If you get a swelling visitor, that it is infection or inflammation. A tumor, even if it is benign or malignant, whatever be your treatment, it can remain static for some time, but it never recede. No, this is given in Das. Das is the wonderful book. You have to read that. Tell me, which is not swelling. Remissions and exacerbation. Of course, that means the swelling is reduced. I'm talking about a clinical examination finding. The answer is induration.
Induration.
See, this what induration, the word should come there, induration. If you have an induration, if you have that induration, you are making it out in your clinical examination, then you okay. So this patient, this was infection because of those reasons which you are talking about. History is suggestive, and the periosteal reaction, and more than that. Go back to the X-ray. Yes, here what you see here, there is a lesion in the metaphysis and lesion in the epiphysis. Correct? Which is the epiphysis lesion? We were all talking about that. Which is the epiphysis lesion? Which are the epiphysis lesion possible? We talked about chondroblastoma
NCD,
Intoxious KB,
intoxious ganglia, intoxious ganglia,
clear
clear cell,
about 3 conditions. So when you have a lesion, at age of 1, he had a surgery done. Has it got any importance to this radiological finding that you have? Can you correlate and explain? Yes, sir. There was that was first infection possibly, which was treated by surgery. Looking at the X-ray, can you say that?
The lateral aspect of the proximal tibia loss of, they made a window.
No, the answer for you is, infections in an infant, less than 1-year-old, that there is no epiphyseal barrier here. The vessels pass from the metaphysis to the epiphysis. So the infection spread along the epiphysis and it reaches the epiphysis because there is no epiphyseal barrier there. But after that, once the epiphysis gets established, the infection in the metaphysis very seldom goes to the epiphysis. So the first infection possibly was solved, and tuberculosis is one such lesion. So that should be the answer to that question. Okay, we'll go now. So gene expert was done and just found to be positive for. Yeah. Now, how do you treat this? Quick. No. Now it is a proved case of tuberculosis.
Is a middle path regimen.
Sorry?
Is a middle path regimen.
Middle path regimes. Don't answer like this because you have not faced anything. There is a question that immediately you will get. You'll be taken to somewhere else. You will end into more and more troubles. So what we do is, what is the regime that we use in our hospital or every hospital? Dots regime. So the answer should be, there is a patient who has got a tuberculous lesion in the bone. The answer is this answer. You should have general treatment, specific treatment, and local treatment. That is the answer. Anywhere you get a bony lesion, your answer should be structured. Answer should go straight. Sir, there are 3 important points here. Not just middle path regime or not just dots. You have to manage these things like that. Right. Okay. So this is what happened with the treatment. it started healing. This 1 year. And three years, this is the picture. So again it healed. This is the yeah.
Recording.
Okay. Tendency in your last younger age group, it can grow. MRI is better diagnosed method. There was an MRI which I think it is deleted off. Okay, there was an MRI. Then radiologic healing is slow. Then epiphyseal and metaphyseal are possible in tuberculosis. That is area. That's what we have learned. So what we are talking about is a benign. We should be able to differentiate benign tumor from infections. That's why this case. Okay, shall we stop case?
But you have just picked up the tempo, sir. Now I think they are.
Or anybody?
Yeah.
Presented with pain and swelling over outer aspect of left leg for the past 6 months. Weakness of left foot and difficulty in walking for the past 1 week. And pain was insidious in onset and was gradually progressive, aching type of pain and moderate intensity. The pain was aggravated by weight bearing, walking, and movement.
So the duration is 6 months. Okay.
6 months.
Yeah. Next slide.
So he consulted a local hospital where imaging was done and biopsy was taken on 2019 December, and they found a weakness and numbness of the left foot with the difficulty in walking since the day 1 of surgery. So on examination, the patient had a high stepping gait. The swelling over the lateral aspect of left of the leg distal to the knee joint was with the sutured wound, and there was local warmth present with the 4x5 centimeter solitary tender swelling over the lateral aspect of left leg. It had smooth surfaces and regular margin involving the head of fibula and continuous with the shaft. And it was hard in consistency and it was non-mobile. Ankle dorsiflexion was not possible. The sensation was diminished over the dorsum and first surface of foot. It's a high stepping gait.
Yeah, it's a high stepping gait. Okay. Is the foot getting inverted?
Yes, sir.
Yes, sir.
Yes, sir. Foot is getting inverted.
What is its relevance?
So that the
Inverters are not
peroneus muscles are not functioning.
Yeah, there is a paralysis of inverters also. No, it's not only the dorsiflexors, inverters are also paralyzed. Next slide. Okay, that is the go next. Yeah, that is the appearance. This is the sutured wound, and this was the finding. Calcium, phosphorus, alkaline phosphatase, all are normal. Okay. Now this is the picture. Now read the picture. Read the X-ray.
X-ray shows of a knee joint in a skeletally mature patient. There is a expansile lytic lesion over the epiphysis of the fibula, and the cortex is thin, and the matrix is the cortex is thinned out, and there is a break in the cortex also.
Yes.
And in the lateral X-ray, there is a lesion has uh, encroached out of the cortex. There is a cortical break. So could be possibly giant cell tumor.
GCT and a chondroblastoma is a
chondroblastoma.
possible.
GCT or chondroblastoma.
There is some subchondral bone. I mean, not subchondral. There is.
It is a giant cell tumor.
GCT.
Are you happy with the description that we were all stressing on this point, how you should proceed with the description of an X-ray? Here it is extending up to the joint line, number one, right? As you said, there is a break in the cortex, maybe because of the biopsy that was done. What about the endosteal border?
There is thinned out.
Balloon. And what is intramedullary border? Look at the intramedullary border. It is sharp.
Sharp. No scalloping.
Because in a malignant scenario, this will not happen. That is why these points are important. And is there a periosteal reaction here?
No periosteal.
No, sir.
Is there a soft tissue involvement here?
No, sir.
So all these points have to be stressed when you are reading an X-ray. Of course, the diagnosis is simple. It cannot be anything else other than a GCT because it is the end of the long bone in an adult after the epiphyseal. That is the first diagnosis that we can have. Okay, which are the other conditions which you can have here?
Aneurysmal
bone cyst.
Yeah, you can have ABCs also, but usually it is not concentrically expanding. It is eccentrically expanding. And giant cell tumor also can have an eccentric expansion. So this
enchondromas also.
Enchondroma. But enchondroma usually is not. This is not the site for an enchondroma, right? Epiphyseal lesions are not. Where is enchondroma usually found?
Small bones of
hands and feet.
And what else you find in the matrix in an enchondroma, in a cartilage lesion, any lesion?
There is some brown glass.
Can be calcification. No, even if you don't have calcification, it can be. Right, that you should understand. If you don't find the calcification inside the matrix, still it can be a cartilage lesion depending on other features you have to do. But what is more important is the endosteal scalloping. In most of the situation, you have endosteal scalloping. So that scalloping is a feature of cartilage lesion. Okay, and how do you differentiate between an osseous matrix and a cartilage matrix?
Ground glass
matrix is
appearance.
clearing.
Ground glass appearance in cartilage.
No, where do you get the glass?
Fibrous displacement.
Fibrous displacement.
When there is a fibrous background, you get that. Cartilage lesions are chalky. If you make a spot with a chalk from the bone that you have, right? Bone is smoky. The description is smoky. Or in the cartilage, if you want to put the description like dot-like, popcorn-like, comma-like, that is the description that is given for a cartilage lesion. And in a osseous matrix, it is smoke-like, cloudy. You should know these terminologies to describe. If you want to say it's an osteogenic sarcoma, usually cloudy or smoke-like. That's the way that and sometimes it may be, you may find bone formation inside. And how do you know it's bone formation? There is trabeculation. So you will see bony trabeculae and the density of the bone is same as the rest. So differentiate between an osseous matrix from a cartilage matrix. And the classical description of a fibrous matrix is ground glass. Okay, these are variable, but classically when you describe these words, you use such of terminologies. Now, what will you do? Why alkaline phosphatase was looked at, Shyam?
GCT, one of the DD is a brown tumor.
Yeah, every case you have a differential diagnosis of a bone tumor whenever you see a lesion and suspecting a case as giant cell tumor. You have to look at that. That's why it was done. Okay, so what will you do now?
In this case, we can go for since it has very thin borders, we can go for a excision, wide excision.
You know what was done? How the patient came here?
Patient did a biopsy. Yes, sir.
That was what was done. So what will you do now? We'll try to collect that biopsy report, right?
Yes, sir.
Yeah. Right. Okay. And this is the MRI. You can see that how the lesion has grown, right? You can see the lesion here. The T1 and T2 weighted images, you can see here how the lesion is appearing. It's not a fluid inside, it's a tissue inside, and this is very classical of giant cell tumor. Okay. So then now what should be done now? We have got the diagnosis as GCT. Now what will you do?
Excision.
Normally, curettage and bone grafting, but in this case, will excise the.
This expendable bone, sir, so we can excise.
Yeah. Sunit, normally it is curettage and bone grafting. Why can't you do this in this particular case?
Because
the expendable bone.
Very cortex is very thinned out. So when we try to do that, the cortex will break and like we cannot put the graft anywhere. There will be no place.
What Naomi said is that is the answer. That is not the other one. It's an expendable bone. You know, for which condition that we take this bone and use it as a graft? Sunit?
Yes, sir.
Which condition we use this? We take the bone of the proximal fibula and use it as a graft. Where do you use that?
Distal and radius GCT.
Yeah, distal and radius. It cannot be DCT. You cannot salvage it. You remove it and then you can go for replacement with the ipsilateral fibula proximal lens. Okay, so it is an expendable bone. That's why we are doing. So what did you do for the nerve?
We'll try to save it if it is not involved, sir.
Otherwise we'll remove it.
We watch for tunnel sign.
Okay, see, the patient has come after 4 days after surgery.
8, sir.
Huh?
We have to observe the patient. We have to wait, observe.
You should. What you should. What we have done here? What are we seeing here in this slide?
We have tagged and isolated.
We tagged and we have done a neurolysis. We have done a neurolysis, and you can see just in the tag there is a scar here, right? Some hematoma-like thing here.
Yes, sir.
Yes. Okay, so this nerve was in continuity. There was no problem. It was not cut through, but the nerve was in continuity. It was conduced. What will you do now? You excise the fibular head. See, you can see the nerve being retracted out, and the lesion is removed, and this is the lesion which is removed, and that is the postoperative X-ray. And what will you do with the nerve? No, we will just left that nerve. What is the procedure that is done? This neurolysis. Suppose it is cut. Imagine it is cut. What will you do, Naomi? When we open, suppose you find that it is cut into two.
We'll try to suture it back, sir.
Yeah, we'll use the right terminology here. Here, what we have done is a neurolysis. Suppose you just cut, you will do a
Neuroraphy.
Neuroraphy. We will do a neuroraphy. Okay. So here we just isolated the nerve, and that was situation. How many is 6 months after the video. 6 months after patient came like this, you look at his ankle and the knee, and what has happened?
He's gained back the function, sir.
Yeah, he has regained the function, and he's touching, and he says that he has lost sensation there. How do you explain all those things now? What was the initial injury, and how he has recovered, and why he took 6 months to recover? What is the explanation?
Partial injury of the nerve was there.
Partial injury doesn't convey many things. There are terminology.
Yes, sir.
Neuropraxia.
Okay, then do you think it is neuropraxia? Anybody else? It took 6 months to recover. Even now, the sensation has not recovered. You can see that his dorsiflexion is still not.
This was neurotomosis.
Axonotmesis.
No, but it was in continuity. You can't say that it's a neurotomosis.
Axonotmesis.
Axonotmesis.
There's only one.
Axonot.
All right. See, and I don't have time. Otherwise, I would have taken you through. See, if it is, the answer in the exam should be like this, sir. This is not neuropraxia because it took 6 months to recover. If it is neuropraxia, it should have recovered in 3 weeks to 1 month time. Usually, in 3 weeks to 1 month time, it will recover. That will be your answer. So when it was exposed, there was no nerve cut. So it is not neurotomosis. So this, because the recovery is slow and recovery has happened like this, the possibility is this injury was axonotmesis, and that is how it is so. That is why even now the distal sensation have not recovered. It will recover. So what will be positive here? What is the sign that you are looking for? Which should look for? It is not.
Sign.
Tunnel sign. When it is recovering, there is an advancing tunnel sign. So if you look at where exactly is the tunnel sign now, that will give you, and when you examine subsequently, the tunnel sign will migrate or not advance. Then you know that it is recovering. So that's the answer. So this, when your clinical examination is done, you have to make out the tunnel sign at which point it is, and that will give you the clue that, sir, this is again. Do you get tunnel sign in neuropraxia? Anupam is there. He has never opened his mouth. I can see him there. Anupam, will you get tunnel sign in neuropraxia?
No, sir. No.
Why?
Sir, neuropraxia is a disruption of the physiological conduction of the bone.
Yes.
So the recovery is quite swift. Whereas in axonotmesis, there is some violation of the anatomy, which has to be.
What violation of anatomy?
Sir, in axonotmesis, there is injury to the nerve fibers, but the sheath remains intact.
So what is? Wait. So you said there is an injury. Sheath remains intact. What is actually damage? What is the actual damage then?
Axons.
The
axons are damaged in axon.
The disruption of the axons.
Axon, what is axon? Axon is axonal sheath, axoplasm, then surface, you have got the myelin sheath, Schwann cells, all these are included, and then you call this as an axon. When you say that, you say that means all these are damaged. That is not axonotmesis.
It is the axoplasm that is.
Yeah, there is an axoplasmic disruption.
Axoplasm, yes.
A tube of balloon, and you fill it with water, and you press on one area. The sheath of that balloon is remaining intact, but the fluid inside is disrupted. Connection is disrupted, and that is what actually happens in most of the fractures when you have a fracture which is pressing on the nerve. That is axonotmesis. Axonotmesis means The distal part of the nerve at the point of injury or compression will undergo what is called Wallerian degeneration. In axonotomesis, this happens. But in neuropraxia, it is demyelination. The Schwann cell conduction is lost. Axoplasm is intact, axonal sheath is intact, and that's the basic difference. So when there is no degeneration, there is no regeneration. Here in axoplasm, when it's disruption, the continuity with the cell body is lost. So the process of Wallerian degeneration happens. After the Wallerian degeneration, there is a process of regeneration. Okay. And that is why you get the Tumour sign. You are tapping on the end of or the advancing head of the axoplasm. There you get the Tumour sign positive. So the answer is simple here. Right. This is not neurotomesis because we have seen it. It is not neuropraxia because it has not recovered in this time duration. It is axonotomesis because there is advancing and gradually it is advancing and the distal part of the sensation have still not reached. So because it is not time. What is the regeneration possible per month after an axonotomesis, Anupam?
1 mm.
1 millimeters per month.
No.
Per day.
No.
1 millimeter per day.
Day.
With this case, can we stop?
So we'll finish with this. We'll wind up this and conclude.
Yeah. So what I was trying to tell you in this particular case, I want to tell you two more important points. Always take a detailed clinical examination. Sit down with the patient. A reference letter given to you. Never look at the X-ray before you examine the patient. See, after listening to the history, clinical examination, you should reach that particular point, whether it's a chronic infection, benign lesion, or malignant lesion. Then you look at the X-ray. X-ray will tell you what it is. Then you decide among this, narrow down your diagnosis to your clinical diagnosis. And most of the bone tumors, we never stop with that. The final diagnosis comes only after a pathological diagnosis. So there is a clinical diagnosis, there is a pathological diagnosis, and then sometimes you need special stains and all those things to reach the diagnosis. And once you have made the diagnosis, then when you come to the staging of the lesions and all those things, I am not entered here because we don't have the time for this. So I think this is a starting of a learning point for you. Start now reading. Okay, so understand the importance of taking history, understand the importance of making a clinical diagnosis, then you verify all those things. Don't send the patient to MRI and go according to the MRI findings. That is what is happening now. It should not happen. That is a final message that I want to give you. Okay, Jess?
Yes. Yeah. Thank you. Thank you, everyone. Thank you, everyone. Bye. Good night.